Good evening. It's clear the time is now for every Australian to do their bit to defeat the coronavirus. Significant parts of the country are going into shutdown tonight. Borders are closing. But it will be up to each and every one of us to help protect lives. We're standing by here to take your questions from right across the country. Things will be different for a while, but this is your show, so we're here to get you the critical information you need. You've got loads of questions tonight, so let's get you some answers. Welcome to Q&A. Hello there, good evening and welcome. Joining me in the studio tonight, he's the doctor turned medical journalist that Australia has turned to, Dr. Norman Swan. Joining us from Melbourne is infectious diseases expert Professor Sharon Lewin, whose team at the Doherty Institute is working on both a vaccine and treatment for COVID-19. And in Canberra, the Deputy Chief Medical Officer and epidemiologist Professor Paul Kelly. And you can stream us from a very safe distance at home on iView and YouTube as well, and join in on Facebook, Twitter and the Gram. Quanda is the hashtag. Now, Paul Kelly, I want to start with you before we get to any questions, because it is clear that many Australians are simply not taking the warnings seriously, and you want to say something tonight.
Yes, Hamish, and thank you for the opportunity to do so. This is serious. No one expected 2020 to start as it has. We've had bushfires, we've had floods, and now this virus. So whilst we've been preparing for many years for a pandemic similar to this, this is unexpected at this time. The world has changed, Australia has changed, and we're all in this together, young and old, and we all need to play our part to get past this crisis that we're in. I want people tonight to really start listening to the messages. Listen to the experts. We've got two others on the program tonight. Listen to them. Keep safe, keep calm, and keep your distance.
And wash your hands. All right, let's take our first question tonight. It comes from Chris McMenamin in Manly in New South Wales. I've been speaking to him on Skype. Chris, your family's in an awful predicament. Can you explain the situation they're in?
My parents and my younger brother are on a ship off South America with 150 other Australians. They're currently, with the assistance of the ship, trying to negotiate a place where they can disembark and get on a chartered flight home because there's currently no commercial flights that are running. The situation is still up in the air, and we understand the relevant authorities are trying to negotiate things, but there's no certainty as to when they can get off.
And your brother has special needs. As I understand it as well, in the last sort of 24 hours, conditions on board have started to deteriorate pretty significantly. Can you talk us through that?
Yes, my brother is, he has intellectual and some physical disabilities, and my parents are his primary carer. This was the trip of a lifetime for them, to go to Antarctica and take Jono with them. But mentally, the situation is taking a huge toll on everyone, particularly as they're having great difficulty in negotiating, disembarking and getting on flights home. I guess we're seeing around the world that borders are shutting. It's becoming more difficult for governments to work together to try and repatriate their people. And this seems like there's a critical point in time now to try and get people such as my family home who are in this unfortunate situation.
What's your question for the panel tonight?
There are a number of passengers on board who are medical practitioners, including my parents. And there are people on board who need essential medicines for their underlying pre-existing conditions unless the authorities can work together to find a way to get these passengers home. It's obviously a very delicate situation, but would you agree that there are real concerns for those Australians on board? And don't we need these medical professionals back with us now to help us face the COVID-19 crisis?
Paul Kelly, we will have a response from the Foreign Minister in a moment, but from your point of view, how urgently does Australia need people like these back to help fight against this crisis?
Well, as I said in the opening statement, Hamish, it's all pulling together, and certainly the health professionals are key to this for all of our care that's required. And this is a very difficult situation, obviously, for this particular family and for the others on board. We know that there are, I understand, 3,000 Australians on 30 cruise ships around the world, and many of them are in this similar predicament. Very unpredictable things are happening. Borders are closing, and not only here in Australia, but international borders. The number of flights that are coming into Australia, but all around the world, have decreased enormously over the last month or so. And so it's very difficult. But I do know that DFAT is aware of the situation and amongst others, wanting to do whatever can be done to bring people back to Australia that want to come back.
All right, we have had a statement tonight from the Foreign Minister, Maurice Payne. It says, we are working with the government of Argentina in relation to allowing passengers to disembark at Buenos Aires, and we're also pursuing options with the government of Uruguay in relation to potential docking at Montevideo. Qantas has also told us today that it is ready to and willing to help in concert with the government if passage to an aircraft can be facilitated. All right, our next question is a video question from DB Porter in Ocean Shores, New South Wales.
We arrived at Brisbane International Airport last Friday morning on a plane full of people from all around the globe. Upon arrival, there were no thermal cameras, no thermometers, no testing, nothing, just a few minor questions and a pamphlet. Customs officers, Border Force officials and duty-free attendants were not wearing masks. Is this as strange and negligent as we think it was? Thanks.
Dr. Norman Swan, we've had so many questions from people who've returned to Australia and seen what they perceive to be very relaxed processes at our borders.
One of the problems that's been throughout this whole episode so far has been contradictions, and it's unsettled the public. And we talk about the borders, closing the borders, and people's experience of that's been different. And we've seen cruise ships discharging, and it's a common story that they've got off at the airport and they just walk straight through, and they know there might be a problem, and they don't seem to be paying attention to it.
Sharon, Lewin, have we simply let our guard down as far as what appears to be a trust system with people coming into the country and being told they must now self-isolate, but really leaving it up to them and not doing much further monitoring of it, if any?
Well, traditionally, in public health, we rely on trust and education of people. That's traditionally how public health works. But this is serious. It's a serious time. We're all in it together, as you heard from Paul before. And there may be a need to sort of increase the amount of observation we have with people in quarantine. At the moment, it has been an issue of trust. I still am a strong believer that's the best way to practice public health, educating and empowering the public, but we may need to increase the levels of observation because of the significance for all of the community when people don't stay in self-isolation.
What should that look like then?
Well, other countries use different techniques. Of course, most of us have mobile phones. They're easy to track. You can ring in every day. Singapore does things like get people to take a photograph of where they are and send that in to the authorities. That is a sort of, I think in 2020, that's the kind of best sort of tracking that we can do, taking advantage of electronic technology and mobile phones. One option.
Professor Paul Kelly, has that been considered? Is that an option that is before us right now?
Yes, and we're certainly learning from other countries. Singapore is a particular case in point, and I've been in touch with people in the Ministry of Health in Singapore to learn what we can from them. We're a different country to Singapore. We're different to every other country that's been facing this crisis so far. Just to add to Sharon's point there, I've been working in public health for 30 years, and during that time I've always been able to trust people once they've got the message clearly about what's required, that they will do the right thing. These are extraordinary times, however, and we're certainly looking at the powers that are available under Public Health Acts in all of the states and territories, and indeed the Biosecurity Act, which we've had a declaration of a biosecurity emergency in the last week, which gives the Minister for Health at the national level quite extraordinary powers to do things if it is deemed necessary.
But can I ask, though, you began this program, though, by saying that you've been planning for a circumstance like this for years. Why is tracking and apps not something that you already have at your disposal?
Oh, look, there are many things that we have at our disposal, and that's one of them. And indeed, those powers that I mentioned.
You already have that technology available to you?
Well, we all have mobile phones, and location services are on mobile phones. So these are difficult decisions to make in terms of people's privacy. But I think we need to get beyond that.
Paul, you haven't introduced these technologies. Singapore has. You've had weeks now to introduce those technologies, and they haven't been done. I mean, and it's not a question of trust. We should be testing every single person that comes off one of these planes, because the asymptomatic spread is what we need to be worried about. And at least you've got a baseline, so you know when they got off the plane whether they're positive or not. You can't guess this. We have a process of testing which is only based on symptoms and contact. It's symptoms, and if you come in contact with somebody, if you're coming from overseas. And symptoms, as we've seen with the Diamond Princess and we've seen with South Korea, are not a good sign of the people who might spread this virus. So everybody coming off a plane or a boat should be tested regardless of whether they got symptoms or not. We need a baseline.
Sharon, Lewin, do you think that's appropriate?
In an ideal world, I think it is. I think it's important to realise that there are limits to resources. We've been testing extensively in Australia, actually. If you look at the frequency of testing per 100,000 population, we're at around 480 per 100,000 population as of yesterday. And Korea, which is held up as one of the sort of best places in the world, is around 600 per 100,000.
But if US with respect, if we take the example of the Ruby Princess, this ship that docked in Sydney, 3,000 people on it, about 1,000 staff. If we had tested all of them, wouldn't we now be in a very different position as a country?
The Diamond Princess, I think I heard you correctly, Diamond Princess as in off the coast of Japan. Then?
No, I'm talking about this boat that came to Circular Quay last week in Sydney.
All right.
And
yes.
It's now been reported that almost 50 people are confirmed cases of COVID-19.
Yeah, well, I was just going to, yes, we know that cruise ships are probably quite different entities to what we know in the community. There seems to be significant spread within cruise ships, as we learned originally from Japan and then subsequently. I think cruise ships are probably a separate indication. I was talking about how we use the resources of testing and where we're going to get the best bang for our buck. At the moment, in a time where the resources are limited, we don't have unlimited testing, for example. We're doing lots and lots to increase our capacity for testing. There are new technologies on the way. There are new strategies to increase the throughput of testing. But while testing has got some limits, we need to direct it to where we're most likely to find a positive, and that is what determines the current rules around testing. However, there are new technologies, and I think we'll be able to expand our testing quite quickly over coming months. Cruise ships are another story. Others may want to talk about cruise ships in particular,
Paul Kelly,
which I think are quite different.
Are we going to change the guidelines for testing in Australia?
Yes.
When?
This week. Mostly the guidelines for testing are about include a travel component, and the travel is decreasing. I'd just like to come back to Norman's point, though, about what we're doing at the border. When we first put in border restrictions in relation to China, there were still quite a few people, Australians, coming from China, the very very epicenter of the pandemic at that time. We actually very carefully looked at over 30,000 people coming off the planes, looking at symptoms, checks by health personnel, testing when required. 2 of them were positive. 2 out of 30,000. So that was one of the reasons why we've gone to this new way of doing it, making sure that anyone that comes in from any country must, and this is a must, and this is a message to everyone out there that's come back in this period, from any country in the world, they must self-isolate. And when I say self-isolate, it means they must stay at home. And different jurisdictions are different. But for example, in Queensland, everyone coming through the border in Queensland is getting a public health order, which they sign, saying that you must stay at home. Every person that's coming into the border, into every airport at the moment, is now having a stat deck with their phone number, their signature, their name, and those are being given to the state and territory authorities as they come off over the border. And it's up to the state and territories then to do what they feel they need to do in relation to making sure people take that message seriously.
All right, well, we do have another question tonight specifically about testing, and it is in fact a federal politician. Senator Rex Patrick has been confirmed positive with COVID-19 today. He's at home in self-isolation in South Australia. Good evening to you, Rex Patrick. How are you doing?
Yeah, good, thank you.
No
symptoms.
How surprised were you when this test came back positive?
Well, I'm very surprised because I have had no symptoms, and as such, when I got the test, when I got the test results, I was anticipating negative, but it turned out to be positive.
And in terms of contact tracing, are you clear on where and how you got this?
I was most likely infected by Senator Bragg more than 2 weeks ago at a Senate inquiry. So that's the most likely source of my virus.
And so what's your question tonight, Senator?
Well, my question is to Paul. The day after I met with Senator Bragg, he had flu-like symptoms, but he did not qualify for a COVID-19 test because he hadn't been overseas and he hadn't been in contact with anyone who was a known COVID-19 carrier. A week later, he became aware of others that had gone to a wedding that he'd been to that had contracted coronavirus, and at that point, he did qualify for a test. If he'd been tested when he first had symptoms, I would not have spent 8 days working in country South Australia. SA Health would not have spent the entire day contact tracing me, and those around me over the last couple of weeks would not be in a situation where they might have to self-isolate. Why is the test criteria so strict? Can you see how 10 minutes 2 weeks ago could have saved so much time and significantly reduced the risk of my infecting anyone? Professor
Paul Kelly.
So several points to make there. Firstly, that wedding that has been mentioned is a super spreading event. So I believe out of the 140 or so people that were at the wedding, there are now 35 or perhaps more cases that have proved positive. It demonstrates, firstly, how infectious this is. It's much more infectious than flu. It does spread quickly. And actually, as Senator Patrick has pointed out there, reasonably short contact can actually allow that to be spread from person to person. So I think these are the messages that we're giving out about people that are sick, not mixing with others, and that asymptomatic carriage, it makes it extremely difficult for us to keep this under control. And so that's why those other social distancing measures we've brought in the last week are also important.
But this is a question, though, about
the testing,
community transmissions and testing. I mean, can you speak to that, please?
Yeah, so the testing, Sharon's already mentioned this. So a couple of things I'd like to say about that. We need to test where it's most likely to be positive, and up to this point it's most likely to be in people that have been returning from overseas. More than half of the cases, of the 1709 cases we have currently in Australia, are directly came from an overseas traveller. So we've been testing those ones first because of two reasons. One, that's the most likely place we'll find it. Secondly,
but isn't it the most likely place because that's where you've been doing the testing? Isn't the data reinforcing itself because you're only focusing on those people that have come back from overseas and those people that have been in direct contact with a confirmed case?
Yes, that's true. We have had up to now a shortage of the laboratory tests. That's well known. We're not only in Australia, but that's a global thing. This is very new. We've had The first tests were in Australia came in within a week of the first cases as we became aware of them. And since then, we've really ramped up testing, 140,000 tests, way more than the US, even with 10 times the population.
I mean, I've got great sympathy for Paul. It's a no-win situation for the Chief Medical Officer here. But the reality is we keep on getting these statistics trotted out that we've done hundreds of thousands of tests and what have you. But if the tests are in the wrong place, it's not necessarily getting us anywhere. And, for example, at that wedding, are we testing everybody who was at that wedding, regardless of whether they've got symptoms? Are we then tracking them down, and are we repeating those tests a few days later?
So are we?
No, I don't. Well, Paul might contradict me now, but for example, with the Diamond Princess, yes, we quarantined people off the Diamond Princess, but we missed people off the Diamond Princess who were asymptomatic, went into the community, and it was predicted on the 1st of March that there would be a hockey stick on the 20th of March, because that's 2 incubation periods away from the virus. So the virus goes underground, it multiplies in people like the senator who are asymptomatic, and then then it burbles up, and you get this uptick, this hockey stick that we're seeing now, can be traced back to inadequate testing of the Diamond Princess. So we're not saying that everybody with a sniffle should actually be tested, but we can be much more targeted after people, repeating tests, going after the contacts, not letting it go. In some environments, 60% of infections come from asymptomatic people.
Okay, I do want to move on from this, but Professor Paul Kelly, if there are going to be changes, what will the new protocols be?
Well, we'll be removing the traveller component, but we're working on that at the moment. So there'll be announcements about that over the coming days. Just back to the wedding, everyone has been seen as a close contact. They're all in isolation, and they're being monitored. In terms of the Diamond Princess, the people that came and were in Howard Springs were monitored twice a day, including temperatures and including symptom checks. Twice a day for the whole time they were there. If they showed any sign of even a small sniffle, recognising they'd come from a very, very intense epidemic, they were tested. Many of them were negative, some of them were positive. There was no one that was removed from there in that 14-day period. Similarly, no one came back from the only people that came back from Japan from the Diamond Princess were people that had been found to be positive. Some of them were asymptomatic on the ship. But they were not allowed back until they'd had 2 negative tests, and those that had been negative but had to stay in Japan for 14 days. So I think that's a coincidence, Norman. With respect, I believe there probably has been some circulation in the community, perhaps as far back as January, before we recognised the issue in Wuhan.
Okay, let's take our next question tonight. It's a video from Claire Seller in Ermington, New South Wales.
As a current Year 12 student, I feel the level of anxiety amongst my peers is increasing when we think about the impact of COVID-19 on our education. We are in one of the most stressful years of our lives, and the additional stress from the way this pandemic is being treated can only be detrimental, affecting our mental, if not physical health. Does the panel think that keeping schools open is the appropriate way to deal with this situation? And what do you see as the long-term impact on the mental health of students?
Professor Sharon Lewin, let me put this to you, because we have been overwhelmed with questions from people across the country wanting to know whether kids should be in school, whether they shouldn't be in school. What is your view?
It's a difficult question, and you can see there's great divisions in what experts are saying. And whenever you have a division in what experts are saying, is because the reason is because there is no clear answer. There's pros and there's cons of keeping schools open, and I'll talk about some of the pros, and then I'll talk about some of the cons. I guess first of all, we know that children do not get very unwell with COVID-19. We certainly know that children can get COVID-19 and can spread it, and that they can do it when they're asymptomatic, meaning that they've got absolutely no symptoms. And so therefore there's this worry that you're going to get spread, and there's going to be taking the COVID-19 home. So there's a number and we know that influenza, for example, schools are a great source of virus and spread within the community. So we look often to other countries and see what other countries did and whether that was necessary factor in the response of closing schools or not. There are some countries that did close schools, such as China, other countries that didn't close schools and had a fairly successful response, such as Singapore.
But Singapore did very different things to us, though, didn't they?
They did indeed.
They took temperatures to every student as they arrived. They took temperatures multiple times a day. Taiwan is the same. Are we right to compare our situation to Singapore on that front when we're not actually doing the same things?
I'm just using it as one example of why there's confusion, so that I'm not using it as a direct copy. I'm just using an example of why there's confusion. So you see some countries that do well that have kept the schools open, and some countries that do well have closed the schools. So therefore there's a question of how important is school closure. That's why I brought up school closure. The big issue about closing schools are all the other impacts of closing schools, and the person that asked the question raised that very well about mental health and education, etc. And finally, big impact on the workforce if you close schools, particularly healthcare workers, which are so essential to our response. So in making this decision, we're weighing up all these factors of risk to the community and also teachers, of course, occupying the workforce, and whether how essential it is or isn't. So I see it, closing schools or not, as a package of interventions. It certainly will increase social distancing. What we're trying to do is reduce the risk of people being exposed to the virus. The less contact we all have with each other reduces the risk. So the question then is, do you do everything to try and reduce the risk to nothing? And we all do want to reduce the risk to nothing. Or do you make some compromises in some settings because there are payoffs with this extreme social distancing? And that's the sort of thinking that's going through. For me, I'm a bit pragmatic at the moment. I think we're in it's a really important time for Australia to get it right, because although we have escalating numbers of cases, we actually have relatively few cases currently, and we've been testing quite intensively since the beginning, since our first case in the end of January. So now is a really important time to get it right, and therefore I think I would err on the side of going a little bit harder now in this precious time we have to stop an escalation of infection. So I would err on closing schools. We're coming up to the Easter break. It's quite a pragmatic move, but I was explaining the reason why it's not black or white.
Paul Kelly, is it still your advice in your position that we shouldn't close schools?
Yes, and I, as Sharon says, I see the counter-argument. My sister's a teacher. I know that it's a struggle for her every day, and I mentioned in a press conference last week that she'd been abused by parents about hygiene and so forth in the schools, and that's just not on, by the way. We all need to be working together. We can't be going around abusing teachers, healthcare workers and people in shopping, in grocery shops. But in terms of schools, this is what we know about this virus, and we're learning more every day, and we give that information every day to the public. First of all, this is not flu. Everywhere where the virus has spread, around about somewhere between 1% and 3% of the cases are in school-aged children. That's very different to flu, where children are super spreaders usually. They're the ones that are often spreading the virus and sometimes get extremely sick. There was a paper published over the weekend which very in some detail demonstrated what had happened in Hubei province in terms of children. Those that got sick, again, very small proportion, about 2.4% of the total cases were children under 15. Only a third of those were 15% were asymptomatic, and about the same number had very mild illness, just upper respiratory tract infection. And only one child, unfortunately, died, but that was very, very low numbers. Second of all of those cases, and this is what has been found in other countries, tend to have come from the parents and not amongst children. Again, very different to flu. And then there's all the effects that Sharon's gone into. I won't repeat them. But closing schools is a big thing. And what we've been trying to do right throughout this is to look at proportionate responses, what actually needs to be done now, thinking of that long-term game, what is sustainable over the long term. This is not a 2 or 4 week thing. If schools close, they are closed for at least the next 6 months, probably for the whole school year. That is a big thing for people like the person that asked the question who are coming into their final year of school. That is a life-changing event. We can't make these decisions lightly, and they may have a place at some point. Some people that feel that point is now. I and my colleagues on the Australian Health Protection Committee disagree.
Let's just put this in perspective. So what we've got in Australia is an only partially targeted testing campaign. We're missing asymptomatics. And so we don't have the best possible... It's not about numbers and gross numbers with testing. We've got an inadequate testing regime. We've got an inadequate quarantine regime, which relies on trust. It is changing a bit in some states. And therefore, we're not actually under control. And the hockey stick illustrates that. So it's doubling every 2 or 3 days. So you get a year 7 primary school student, and Sharon's right, it's lower numbers now. We've got a chance now to get it under control. Now, when you've got not an adequate testing regime and you've not got an adequate quarantine regime, what's left to us is social distancing. And all the mathematical modelling, including it comes out of Sharon's group, tells you that social distancing is what makes a difference. And you've got to put the foot on the brake harder on social distancing if you're not doing the other stuff well.
So if that's the case, Paul Kelly, I know you have your own modellers. Do the numbers that you are seeing show that by shutting schools now, you will do more to flatten this curve?
So school closure is one of our potential things we can do. It's in our plan, and we've been very open about that as something we would consider at some point.
Sure, but with respect, that's just a very straightforward question about whether your modelling shows that by closing the schools, the curve would flatten. Does it show that?
So this goes to Sharon's point as well. When you have a range of interventions, it's hard to know which one would work the best.
But the modelling from London's clear, Paul, that it's not the magic pudding here, but each time you put your foot on the brake, you get a greater flattening of the curve. And the Imperial College London group found that, in fact, closing schools in their model, and they're some of the best modellers in the world, actually had the biggest effect. And it's a terribly difficult decision. I mean, it's just an appalling decision to have to make. But they showed that it was the biggest thing you could do to make a difference to the curve. OK, as we've already mentioned, been pretty overwhelmed with questions for tonight. We're going to do a sort of rapid-fire round of questions with basic questions, in fact, about people's day-to-day lives and how they're changing right now. So the next 2 video questions are from Sandy Thomas in Sandringham and Jessie Giles in Tambar Springs, New South Wales.
I'm a fit and healthy 67-year-old. I play golf 3 times a week. I have 2 grandchildren, 5 and 11. I'd like to help care for them during the school holidays, but I'm not sure whether it's safe for me to do so, and for them.
Hello, my name is Jessie. I'm 13 and live on a farm in New South Wales. Thank you for listening to my question. My question is, if me and my family isolate for 14 days, can I go see my grandmother, who also is isolating? I really want to see my grandmother. Thank you.
Hi, Nana!
OK, let me put that to you, Sharon Lewin. Can grandparents babysit? Can kids in isolation go and visit their grandma?
Yeah, difficult one. I don't think grandparents can babysit unless they're practising some social distancing, and with young kids that's really hard. And the reason why these very difficult advice is coming is because older people have a much worse outcome from COVID-19. Data from China shows people over 80 have 15 to 20% mortality rate, and it's still elevated even over 60, up around 3 to 5%. So that's why there's this great effort to protect the elderly, and particularly the very elderly. So how would you protect yourself as a grandmother? Well, if you go through, or grandparent, if you go through social distancing, it's to keep a fixed distance away from someone, all the things that we're talking about, hand hygiene, etc. And that is really difficult with the younger grandchild. Perhaps a 5-year-old, 11-year-old could work, who would be able to respect those distancing rules. Now, out of quarantine, again, once you've done I didn't understand the reasons for the self-isolation. Well, let's just say it was coming back from overseas, where we're currently recommending that anyone that comes back from overseas undergo self-isolation for 14 days. And the reason for that is they may have had an potential exposure, and if they were to get sick in those 14 days, we wouldn't want spread over that time, even if they were asymptomatic. So at the end of the 14 days, you can come out of self-isolation, and the same rule would apply if you were to mix or see an elderly person, is to keep that physical distance. It's just a lot harder if you've got little kids and they jump on top of you or pick them up, and you can't control that.
All right, that sounds like a no. The next two video questions are from Catherine Martin in Wollongong and Matthew Best in Ulladulla.
Dr. Norman Swan advised us against swimming in chlorinated pools. What is the risk as far as COVID-19 is concerned in swimming in the ocean or in ocean pools?
Hey guys, I'm a fit, healthy 29-year-old from a small coastal town on the south coast of New South Wales. I've just flown back in from a trip to New Zealand and I'm currently on the 4th day of a 14-day quarantine. I was just wondering what the guidelines were on exercising and in particular surfing. I'd like to both surf on my own, run through the bush on my own. Am I permitted to do this? Can I exercise and surf out in the open where I'm easily able to avoid contact with anyone else?
Okay, so Norman Swan, the first question on swimming in ocean pools and in the ocean.
So this is loose lips sink ships. So what I actually said about, we've got a huge number of questions, and I'm sure Paul and Sharon have got questions too about swimming pools. So the story about swimming pools is actually the chlorine probably kills the virus. So it's not the swimming pool itself, it's the fact that you're mixing with a lot of other people. And the general principle here is the more that you mix with other people, the greater, I think Sharon said that at the beginning, the greater your risk of actually getting infected. Okay. And in that sense, a crowded beach is no more different from a crowded swimming pool. That's really the issue there.
Ocean swimming, that kind of thing?
Well, if you're on quarantine, you're on quarantine. You don't go out because you just can't guarantee.
So Matthew in Ulladulla, no bush running?
No
surfing? He
stays at home. Paul can fix me up on this one, but I don't think he can, no.
Paul, is that agreed?
Yeah, the quarantine means stay at home, sorry.
All right. The next question is a video from Lewin in London, in the United Kingdom.
I'm wondering, with the colder months about to approach Australia, as a government, are we confident, are we prepared for the changes that the actual seasons will bring for this coronavirus outbreak? Are we prepared to manage the spikes that are going to be coming?
So Sharon Lewin, winter, does that make this scenario different for Australia? And take us forward the next few months. Where are things going to be at?
Yeah, winter does make a difference. It's not because coronavirus necessarily gets worse in winter. We don't know the answer to that. The big concern with winter coming is that flu is still around, and so having flu together with coronavirus is not a good combination because both give respiratory illness. Plus, winter means a lot of people are indoors. In the absence of all this social distancing, you'd be indoors and mixing and in close contact with other people, and that's also not so good. We know that many viruses have seasonal variation. We don't yet know the full answer for COVID-19 and whether we will see dramatic increases in winter compared to summer months.
Your teams have been working on both treatments and vaccines. Is there anything positive for us to look forward to in the coming months? Because we're told vaccine is actually a long time off.
Yeah, we haven't spoken a lot in the public around treatments, and I think that they may play a very important role while we're waiting for a vaccine. As you just said earlier, Hamish, vaccine estimate, even though vaccines often take years to develop, we potentially could have something in 12 to 18 months. But I just want to talk about treatment for a minute. So at the moment, we have no specific treatment for the virus. People get better on their own, or they get better because they receive supportive care in hospital. But if we had a treatment, an antiviral drug that blocked replication of the virus, it could potentially do two things. It could potentially improve outcome, people don't get so sick and don't die, or also reduce transmission, because most virus transmission is related to how much virus you have on board. We know lots about that, particularly from HIV. And just recently, we've become aware of one drug in particular. It's actually an arthritis drug, a very small study, but being tested now quite widely, showing that that drug reduced the amount of virus that we could measure in someone's swab. And we actually can measure the amount of virus quite accurately, and it definitely decreased with this particular arthritis drug. So one thing that we might see in the not so distant future is a lot of understanding about drugs that block replication, and that could have implications for both clinical outcome as well as how infectious you are. So I'm a little optimistic about that. A vaccine, there's lots going on the vaccine front, lots of different trials. One vaccine now in what we call phase 1 trial, human studies looking at safety. We'll see that field accelerate quickly, but it still takes time to make sure you've got a really safe vaccine and then also have something that works.
Norman Swan?
Everybody's hanging out for a vaccine. It's really important. It's amazing the technology that is being deployed around the world in Australia and Queensland and overseas. There is a worry about the vaccine, which people really need to know, and it's why it might take a bit longer. So I understand that when they were developing a SARS vaccine and they tried it out on primates, what happened was that it was fine, it looked safe, and then when they were challenged with the infection, they actually got seriously ill, and you got an overreaction of the immune system similar to the fatal disease that SARS caused. So it depends on how closely related this virus is to SARS, whether the vaccines have a different technology. Sharon knows a million times more than me about this, but somebody at her institute was involved in developing that vaccine, and there is a potential risk here, and it may delay the development. I don't know what Sharon thinks about that.
Will it?
Yeah. Can I answer, Hamish?
Go for it.
Yes. No, that's exactly right. The immune system is very complex. We generally make good vaccines generally make something called antibodies, but antibodies are not all the same. So you can have good antibodies and bad antibodies, basically, and we need to really understand that the antibodies that the vaccine's inducing just, get rid of the virus and aren't causing other activation of the immune system, exactly as Norman says, which is why you need to really understand your vaccine in different animal models, usually more than one animal model, and we're still developing animal models. And then also know that it's really safe in humans because you're about to give it to millions of people. So it will take some time. Though the optimistic side of this, as Norman alluded to, is that there are many new technologies, and some of these newer technologies that actually use the genetic code of the virus in order to make the vaccine can be ramped up with production very quickly. That's another big barrier for vaccine development.
Okay.
We might get a vaccine, but then to make enough of it and to make it available is another big challenge.
All right, a couple more of these quick-fire questions. This video is from Louise McCallum in Linfield.
Hi. We keep hearing that the virus doesn't survive in high temperatures. Is that actually true? And if so, does that mean that we should be consuming hot liquids? My barista would especially like to know that.
Paul Kelly, you can deal with this one quickly, please.
I think the answer is no. Every day, myself and Professor Murphy get the magic cure for COVID-19 sent to us by email or other methods. Unfortunately, there is no magic cure. There are some hopeful medications and some clinical trials going on, as Sharon has mentioned. We're all hanging out for the vaccine.
Okay. The next question is a video from Pamela Virtue in Potts Point in New South Wales. She's an 81-year-old with what she says are less than ideal lungs.
Would we, Wrinklies, in the case of a ventilator shortage, would we, as in Italy, be denied the use of a ventilator in an emergency?
Norman Swan, what's the reality?
Well, the reality depends on whether or not our hospitals get overwhelmed. So the predictions at the moment, if this hockey stick doesn't change that much, is that we'll be out of ICU beds in New South Wales. Victoria will be behind that by April 10th. And in that case, ICU physicians will be faced with some very difficult decisions. And overseas, 30 to 40% of ICU beds are filled with young people. There's one ICU, I'm told, in Melbourne at the moment where there's an 18-year-old and a 40-year-old in ICU. And so these are difficult decisions. And if you're already sick and frail, you don't necessarily put up very well with the ventilator or the heart-lung bypass, which is the ultimate treatment.
Paul Kelly, do you agree that our hospitals will reach capacity by around April 10?
No, I don't. There is a laser-like focus on looking at what we have in terms of current ICU capacity, current intensive care capacity, not necessarily intensive care unit capacity, ventilators and the like. We are really ramping up what we can do there. We've been assured by our state and territory colleagues that a doubling of capacity is a relatively simple thing. A tripling of capacity is also possible.
Capacity of ventilators or capacity of ICU beds?
Well, the two mainly go together. But the point is, I guess, back to the hockey stick, we can't be distracted from the public health measures that we've discussed already about making that curve much flatter than might be the case without those sort of interventions. So it's the first thing, but so that will decrease the demand. The second part is really ramping up what we have in intensive care. We have strategies also to take pressure off the hospital system more broadly, not just intensive care units. So look, we are not Italy. I've seen some people say when they look at the curves of what Norman's referring to there, the epidemiological curve, that we're 2 weeks behind Italy. We are not 2 weeks behind Italy. We have been testing and finding many more mild cases. Italy mainly tested the top of the pyramid, the very serious cases as they came into hospital. That's what their first 1,000 were. Our first 1,000 are mainly community cases, mostly involved with travel from overseas. We've only had 20 people through this whole period that have been in intensive care. We've had 7 deaths, unfortunately, all in older people. The average age is, the lower age is 77, the average 86.
Can I just check with you about capacity though, because this is an important point, and it's a question we've had from many people. You have said that you expect between 20 to 60% of the population to get COVID-19. Is that still the case?
Well, that's if we didn't have these interventions and didn't flatten the curve. That's what that was referring to. So just we know the biology of the virus. We know what there's been talk about herd immunity and so forth. What we would also need to get to if a vaccine was produced and was successfully rolled out into the population to protect all of us, and that's where the 60% comes from. So that would be an uncontrolled epidemic.
Sure, but you had said that 20% is best case scenario. Is that still the case?
We may get less, but that's 20% without the major interventions that have gone into place this week and with potentially more to come.
Okay, so you actually think it would be lower than 20% of the population that would contract COVID-19 now?
For the time being, we need to be really clear about what the end game is here, Hamish. So we're all hoping for a vaccine in the future. If we get a vaccine that works and is effective, then we're protected and fantastic. We can really defeat this virus. If we go into lockdown, as many people are suggesting we should do now, this is not a 2 or 4 week phenomenon. It's until we get the vaccine, and if we do that, less people will be infected. But every time we take our foot off the brake, and I've heard Norman talking about this very well today in relation to that paper he mentioned earlier from Imperial College, Every time we take the foot off the brake, more people will get the infection. That's just the way the infection will be. We cannot completely eradicate this infection unless we get a vaccine.
So is, in some sense, herd immunity part of our ultimate plan if there is no vaccine? Is that what you're saying?
Well, herd immunity is the alternative to total lockdown and total closure of the borders and so forth. That's one option. The vaccine is another option, and herd immunity is another option. We're not pursuing that one at the moment because that means many more people will get the infection.
But we don't have a vaccine, and we're not doing total lockdown.
We're not, but there's been many of the things that have been introduced in the last couple of days which are heading in that direction.
Right.
But the other option might be, if I could just jump in, after severe social distancing measures, which when you say lockdown, that might be confusing for people, of what that means. But you have a range of different social distancing measures, and we may need all of them, but we maybe could get away with some of them. So one strategy is that if you relax some of those measures, you have really souped up testing, so you just pounce on every single infection and its associated contacts. And if we had lockdown and really reduced the numbers of infections and had time to really ramp up those aggressive testing measures like what South Korea and Singapore are doing, that's another potential exit strategy, or ways to relax the severity of social distancing.
All eyes are on China at the moment, if you can believe what's coming out of China, and it's hard to know, but they're taking the foot off the brake, and only 1% of people are immune. So a lot of people are vulnerable, and it would be interesting to see what happens. The London group suggested actually pulsing the pedal, as Sharon said, take it off for a little bit, see what happens, because Paul is right. People don't realise what we're actually entering now. We have not experienced for 102 years. And this is ancient epidemiology. This is difficult stuff where we're changing the way we live for an indefinite period. It's actually, it's clearly scaring government. And when you put your foot on the brake, you can't take it off. I understand all these decisions. And then what happens with the curve, and here's the uncomfortable truth, is if you actually look at these epidemic curves, they come from the 1918 flu epidemic. It's not convincing that you actually save lives in the long term, but the hospital system, you don't kill as many doctors and nurses, to be blunt, and your hospital system stays intact, and you're able to have a much more humane society along the way. It's like planning for battle and working out at the Somme how many you're willing to lose. And it's terrible decision-making. I'm not saying terrible decision-making is taking, but it's terrible to be in the position to have to make those decisions. But it's a profound change we've never experienced before in living memory.
We wanted to look a little bit more closely at one of these places that is taking a really focused approach to tracking down cases. And so we're going to take a look at Taiwan briefly, because it's got a similar population size to Australia, 23 million, but only 169 confirmed cases, 2 confirmed deaths so far, even though it was predicted to be one of the worst case scenarios globally. I've been talking to Dr. Jason Wang, a paediatrician and policy strategist at Stanford University.
They had merged the immigration and customs database with the National Health Insurance database. That allowed them to quickly identify people who had traveled to epicenters, these hotspots. And so when the doctor sees these patients in their clinic, they are alerted that they have been to areas where there's COVID-19, and then they took precautions when they see them, and then they order tests.
Dr. Wang, Taiwan's also been pretty rigorous in checking people's temperatures, coming into the country, going to schools, going into public places. How have they done that? How effective has it been?
So even before COVID-19, they have been doing that. So as you enter the country, there's a scanner, and if your head lights up, then that means you have fever, and they will ask you to step aside and check for additional symptoms. And they've been doing that in regular times, but definitely more rigorous during COVID-19. In schools and public buildings, they check every student's temperature and every visitor's temperature. So if somebody has fever, they will just stop them from going to the building and ask them to, seek additional care and make sure that they don't have symptoms of COVID-19.
I've also read that after the SARS outbreak, Taiwan established a national coordination centre for a situation like this. Has that worked?
Yeah. So the National Health Command Center was established in 2004, a year after SARS. So the command center is a compound that could host 100 people. And so when this epidemic started, they activated the command center. So people started to work there 24/7. And so data will come in from local governments and the central government and get analyzed and then get reported so that decisions could be made. So this way they could make decisions based on data and then report it to the public in a media room, also at the compound, at the National Health Command Center. So that way the public will be informed. And this really builds trust because they were using real-time data to inform decisions. Then they would then tell the public why they're doing it and what they're doing.
Professor Paul Kelly, it's pretty clear now that communicating this stuff to the public is crucial. Do you accept that mistakes have been made up to date?
Mistakes in terms of communications, do you
Yeah.
mean? Look, I think we need to be clearer with our messaging. I think that's come through from many sources, so we're certainly listening to that. I would say that between myself and Professor Murphy, we have stood up and done press conferences 45 times since the 21st of January. We've got a lot of information on our website and people are going to it. We've had 30 million people go to our website. We have fact sheets for so many fact sheets for specific industries, for specific circumstances, and to explain the virus. We were late with our social media campaign. I recognise that, but now's the time when people need to be listening. And I made this point the other day, Hamish, that communication is a two-way thing. People are really primed to listen. We are trying to get those messages out now in as many ways as we can.
I think the big message from Taiwan is that they're unashamed and unembarrassed about using data, linking data, and actually quite personal data for the public good. We are too nervous in Australia to link. We do some linked data, but we could now be using this opportunity to link data on a massive scale and actually get synergies here and be able to do something similar to Taiwan so that we know what's going on and we can actually measure things, and we need to actually get over our fear of data.
Could it all be communicated better? Just on that very briefly, because we have to take one last question.
I think it's got better. I think they had a terrible week 2 weeks ago with the football and the Grand Prix, and I think it's settled down and got a lot better.
Should there be set daily briefings at particular times? Would that help?
Well, I've suggested what they should do is every day they should publish the curve, and that immediately would actually, the government would take control of the agenda rather than people like me talking about the curve. They should just talk about the curve, and the whole of Australia will get behind it and understand the dilemma.
Why don't you do that, Paul Kelly?
Can I say...
Go for it, Sharon.
I was just going to say one thing about Taiwan, Singapore, South Korea, countries that are Hong Kong that actually have done really well here. And a common thread to all of them is that they experienced SARS and South Korea had MERS, another coronavirus. So those governments and those populations felt how painful these sort of outbreaks are. And I think that gave those governments license to go really hard and early and hard, which was acceptable to people in those countries when there wasn't a lot of coronavirus there or even around us. So I think this experience will change us forever in many ways, but particularly with that lesson around sort of taking control very, very early, which I think would have been unacceptable to many Australians very early in our outbreak.
Okay, one last question tonight comes from Peter Strokorb in St Ives.
Hi, my question to the panel is this. Why have both the media and some of the politicians focused on the rise of new cases, the death rates in various countries, including Australia, and the fears and spread fear and loathing about the virus, which has sent shoppers crazy? Why has there been not enough communication and information about the very low mortality rate of the virus and that it's not an automatic death sentence once you contract it? Thank you.
Paul Kelly.
Every time I talk about the virus, I talk about it mainly being a mild illness for 80% of people, and that's a clear component of it. And to give people hope, the issue with as people are survivors and leave hospital and so forth, we've also been open about that. But just to be clear, this is not a minor illness for some people, particularly elderly people. The mortality rate, as Sharon mentioned, is frighteningly high. And so we need to all be doing our part as a society to protect the people that are most vulnerable. We've also, in other parts of the world, found people that are not elderly, in their middle ages, so from 30 and up, who have been in intensive care, who have got very severe illness and died. So, yes, for most people it's a mild illness, and I've been very open about that, as has others that have talked about it.
Okay. Well, that is all we've got time for tonight. We're leaving you with some music, but first to our panel, Dr. Norman Swan, Professor Sharon Lewin, Professor Paul Kelly, thank you very much for joining us, and I do hope as this goes on that we can have you all back to continue the conversation. And to all of you who send in your questions, we're so grateful. We're going to keep doing this week in, week out, so do please keep them coming. Next week, we're looking at how this hits every Australian home, family and wallet. And in these unusual times, it's obviously hard to get together, connect and enjoy music and a lot of the great things in life. So we're going to commit ourselves now to try and bring you as much of that as we can here at Q&A. Next week, there'll be a huge treat. Singer-songwriter Montaigne will be with us. We're obviously the next best thing to performing at Eurovision, of course, which has been cancelled. And tonight, I'd like to introduce to you an incredible talent who sings and performs and writes and makes people laugh. She's been thinking about love in the time of coronavirus. So as we say, take care, wash your hands and good night, would you please enjoy the incredible Bridie Connell.
This song goes out to all the romantics stuck in quarantine. I know it's hard when you can't be with the one that you love, yeah. But don't despair, you know. Isolation doesn't have to be unsexy. Listen to me. I said I wanted to get you alone, but I didn't mean it quite this way. I wanna love you, you know I do, but from 15 feet away. Maybe this is our chance to really get connected through Wi-Fi and devices that have been thoroughly disinfected. I know it's hard and you miss your girl and you feel like it's the end of the world. You feel like it's Armageddon, Armageddon, but Armageddon it on. You got my heart and you got my soul. Boy, I wanna touch you, but not without a 10-foot pole. Armageddon it on, yeah. This social distance has my love life suffering. Video chat don't work because of the buffering. Boy, you know I like you. I think you're a solid 10.
10 times 5.
No, I'm not ghosting you. It's just the NBN. I know it's hard, but we gotta persist if we want the human race to continue to exist now. Armageddon, Armageddon, Armageddon it on.
Where'd you get it from?
You got my soul and you got my heart. I wanna love you, but I love you from 1.5 meters apart. Armageddon it on. Get down in the lockdown. I don't have one lover. No, you know I've got plenty. COVID-19. Have you met Glen 20? Maybe the social distance will bring us closer. By the way, you should support your independent grocer. That last bit wasn't really relevant to this song, but it is very important now, especially in this changing economy. Yeah, Armageddon, Armageddon, Armageddon it on. Ooh, I wanna give you a kiss on those sweet apocalypse. Armageddon it on. Okay, everybody. When I say wash, you say your hands. Wash. Oh, no, public gatherings. Armageddon, Armageddon, Armageddon it on. Treat them clean and keep them keen. And for God's sake, respect the quarantine. Armageddon it on. Yeah, yeah, yeah. There ain't no aphrodisiac like knowing that our actions will help the human race bounce back. Armageddon it on. away from each other.